Thank you, Dr. Hill, for that kind introduction. To me, the issue is not malpractice or tort reform. The issue we need to be focused on is patient safety. And are we handling that problem in the right way? And the answer is no, we're not. Now, most of what I have to say is in a publication which is out on the table outside the door. It's called Solving the Problem of Patient Safety. So if you like what I have to say, you might want to get that. And also, Peter mentioned my blog. We also send out a health alert twice a week, and the health alert brings you back to the blog. If you're really interested, how many of you get my health alerts? Okay, not enough of you. All right. Well, if you're interested in health policy, you got to get on this list because it'll take you to the best blog on healthcare that you're going to find on the internet. And you can just give me a card and an email address, or you can fill out this form that's also out there on the table. All right, I said the problem is patient safety, not tort reform, so let's look at some numbers. The starting fact is that every time you and I go into a hospital these days, our odds of dying for some reason other than the disease or injury that took us to the hospital are between 1 in 100 and 1 in 500. These are called adverse medical events or iatrogenic events. They are deaths that are caused by the system itself rather than by the disease that the patient had to begin with. The death can be caused by a mistake that the doctors make. The death can be caused by an infection that was acquired there in the hospital. But just again, your odds of dying from some reason other than the reason that brought you to the hospital are between 1 in 100 and 1 in 500. And just to put that in perspective, U.S. regulatory agencies have traditionally held a standard of risk of 1 in 1 million. In other words, for the EPA, no risk is acceptable if it's higher than 1 in 1 million. Over in the hospital, we're at 1 in 100. If the EPA were regulating our hospitals, it would close them all down. In terms of the sheer numbers involved, every year it's about as many as 187,000 people dying from adverse medical events in our hospitals. And for the medical system as a whole, we're looking at 6.1 million injuries. Now, an injury can be anything from a minor bruise because a patient fell down in a hospital to a child that's brain damaged for life. So injury covers a lot of territory. But in any event, we're talking about some pretty serious problems here. Now, we can actually put a dollar value on all this, and non-economists are sometimes a little uncomfortable when economists do this, but our regulatory agencies do it. And economists have been doing this kind of calculation for some time. What they do is they look at the willingness of people to trade off risk against money, and usually they're doing it in the labor market. So if you want to induce people to take riskier jobs like becoming a policeman or a fireman or coal miner, doing something that involves higher risk, the question is how much higher wage do you have to pay people to take this higher risk? And based on that trade-off of risk against money, economists calculate an implicit value that people are putting on their life, and the average, by the way, is about $7 million. Now, how many of you would give up your life for $7 million? I didn't see any hands. How about 70 million? How about 700 million? Would you think what you could do with 700? Yeah, well, there's a hand. Okay, I mean, you could give it to your heirs. I mean, you can endow the Georgia Public Policy Institute. I mean, there are all kinds of neat things that you could do with that sum of money. But that's not what we mean here by a value, implicit value of life. What we mean is what kinds of trade-offs are people willing to make when the change in risk is very small and the amounts of money is small, and then based on that trade-off, what can we say about the value of life as a whole? It's about $7 million based on the trade-offs people are willing to make, but it differs at different age levels, and that was important for a study we did that was published in Health Affairs not long ago. So based on those economic studies, by the way, for injuries, it's about $20,000 per injury. So based on those studies, we made a calculation of the total amount that it's costing us for all these adverse deaths and injuries in the system each year. And the number we got was somewhere between $400 billion per year and almost $1 trillion is the loss of life and limb from adverse medical events. In terms of the healthcare spending as a whole, it's between 18% and 45% of the total amount that we spend on health care each year. One way to think about that is that every time our health care system spends $1 trying to cure diseases and save lives, 45 cents of harm is being caused. These numbers, by the way, are several times larger than the estimates of the cost of the malpractice system. So we do have a safety problem, and if we ignore that safety problem, then we end up reforming the system but not helping the patient. So I want to help the patient in a maximal way. Now, what's wrong with the malpractice system? Well, first of all, only 2% of all real cases of malpractice ever result in a lawsuit. And that's a rather amazing number. It means 1 out of every 50 times that doctors are negligent, only 1 out of 50 is a suit actually filed. And then among all the suits that are filed, 37% do not involve malpractice at all. And then after all is said and done, you go to court and an award is given. Less than half of all the money actually goes to a plaintiff. The rest of it is being spent somewhere else. So just about everybody who looks at this system, other than a trial lawyer, is convinced that it's a lousy, lousy system for helping patients, for redressing wrongs, for avoiding future harm. Furthermore, only 1/4 of all of the adverse medical events are actually malpractice. Another 30% or so are classified as preventable deaths and injuries, but they didn't rise to the level of malpractice. So malpractice is when the doctor gives the knee replacement to the wrong knee, or the hip replacement to the wrong hip. Negligence is usually something like dying from an infection. That's considered, preventable is dying from an infection. Those are considered to be preventable but not negligent. And then 40%, the largest category of all, we just call acts of God. Because nobody knows exactly how to prevent them. They occurred. They're not obviously preventable. They didn't involve negligence. So the largest category of all, we don't even really know why they happen. Now the problem, another problem with malpractice is that you can see it's only 1/4 of the problem, if even that. And the problem with focusing on that 1/4 is just like Dr. Hill said, in order to not be sued, if that's where your focus is, you'll order all these extra tests. Well, every time you order an extra test, you run the risk of causing harm to the patient from those tests. So you're putting the patient at risk in other categories in order to avoid the malpractice category. So for all of those reasons, this is a really, really lousy system. And on top of it all, if we just took the money that we're now spending on malpractice, the defensive dollars, the court costs, the judges, the trial, and so forth, if we just took all that money, we could give every family of a person who died from an adverse medical event $200,000, and we could give every victim of an injury on the average $20,000. So we could give ample compensation to patients without any of the trial lawyers. What I want to advocate here this morning is what I call liability by contract. If you want to, you can call it liability without fault, but I want to underscore the contract because I intend for it all to be voluntary. It's a way for patients and doctors and hospitals to opt out of the traditional malpractice system, just by contract. So we agree that if something goes wrong, the patient's going to be compensated, and we're not going to go to court. We're not going to have lawyers and depositions and judges and juries. Now, you might ask, why do we need the legislature to do anything? Why can't the patients and the doctors and the hospitals just sign a contract on their own? Well, as a matter of fact, they do. If I go in the hospital as a patient, the hospital is likely to push some form in front of me, and I'm unlikely to read it, but I'll sign it. And what it really says is that if I die in their hands, no matter how negligent they are, I won't sue them. So let's say the worst happens and I die, and my family's down at the courthouse suing for malpractice, and the hospital brings in the contract. And they said, well, Judge, John Goodman signed this contract. He said, we could do whatever we wanted to, and if he died, that was his tough luck. And what the judge has said in many, many cases like this is that's not a real contract. When patients go in the hospital, they're scared, they don't understand what's going on, and that isn't a true meeting of the minds, and so they simply throw the contract out. So these contracts do not prevent malpractice suits. They don't accomplish what they're intended to accomplish, and that's why we need the legislature. We need the legislature to say, what would a reasonable contract be? And a reasonable contract might be worded such that if the patient dies from an adverse medical event for any reason, then the family gets compensated, let's say, $200,000. And you say in law that this is reasonable. You make it widely available to people to know and understand, so that when people go into hospitals, they understand that's what the compensation is. I would like to leave it open so that if that's not enough money for the patient and their family, they can double the insurance premium and double the amount of compensation and make it $400,000 or $800,000. The point is, however, that the patient and the hospital know in advance what's going to happen, and I would have this cover all adverse medical events, not just the malpractice. So it covers the malpractice, it covers the preventable, it covers all the acts of God. If you die for some reason other than the reason why you went in the hospital, that you get compensated. There is no need here for any lawyers, no need for any courtrooms, judges, or juries. It literally is liability without fault. Most of the time, the hospital is going to own up to it because it's in the self-interest of the hospital to do so. But there will be a panel, independent panel, that will review the hospital records and determine whether or not an adverse event has occurred. And that is not always obvious, and sometimes there can be reason for dispute and argument. But most of the time, this should be a smoothly functioning system. Now, what we're actually doing, again, is asking people to give up their common law rights to sue in return for an understanding that if something goes wrong, they will get compensation, and they know exactly what the compensation is going to be. Now, what are the advantages of this? Well, first place, we get rid of all the lawyers, the judges, and the juries, because they're not adding anything very valuable to any of this anyway. Secondly, we can take care of all the sympathetic cases. I mean, think of yourself on a jury. Something's gone wrong with the birth of a child. This child's going to be brain damaged for life. You know the family doesn't have any money. You know the hospital and the insurance company do have lots of money. And so there's a really strong temptation to help this family out. Okay, well, there's a better way of doing it. And the better way of doing it is before the birth ever occurs, that you have a contract that has insurance for this kind of outcome, so that all the sympathetic cases basically are taken care of. Third, the insurance companies now are going to become the monitors of hospital behavior. Basically, what we're going to have is episodic insurance. And the hospital is going to contract with an insurance company to basically insure all the lives of the people who enter the hospital. If something goes wrong, the insurer pays off. But any insurer that's going to be behind that contract is going to be then carefully monitoring what the hospital is doing. And if one hospital has more deaths and injuries than another, it'll pay a higher premium. If one doctor is killing people, they're going to say, we're not insuring that doctor anymore, get him out of here. And now you have monitors that are in the position to actually monitor. The patient is not in a position to monitor the quality of what's going on in the hospital. But the hospital itself is, and the insurance company is as well. And finally, we create here really good incentives. And most important of all, the hospital begins to understand, well, if anybody dies in the hospital for any adverse cause, it doesn't matter whether it's malpractice or preventable or act of God, for any reason, it's going to cost us, in my example, $200,000. And so if we can prevent a death for any reason, that's worth $200,000 to us. So the hospital all of a sudden acquires good economic incentives to get its mortality rate down and to get its injury rate down. And you know what? Once it's faced with incentives like that, it's going to discover that behind the acts of God, there are really human things going on, and it's going to discover how to create a safer hospital environment. So that's my quick overview of how to do it. I think at the end of the day, we'd have a safer healthcare system, and one that would be better for doctors to practice in, and certainly safer for the patients. Thank you very much.